Good day, everyone. I'm Dr. Amitabha Chattopadhyay, pediatric cardiologist from Narayana Super Specialty Hospital, and I'm accompanied by my colleague, Dr. Debasree Gangopadhyay, an interventional cardiologist from Rabindranath Tagore International Institute of Cardiac Sciences. And we are presenting a case of an aortic pseudoaneurism in a case of post-PDA ligation, which we thought would be very much interesting for the audience. So as we describe the case, this is an 18-year-old young gentleman who presented with hoarseness of voice and hemoptysis after bacterial ligation, which was performed 2 years back. The examination revealed well palpable and equal pulses in all the limbs, normal vital parameters, and a soft systolic murmur at the left infraclavicular region. Chest X-ray showed mild cardiomegaly with wide superior mediastinum. Echocardiography showed continuous flow within the aortic ampulla, flowing into an aneurysmal structure beside the aorta. There was no demonstrable residual ductal flow. CT angiogram chest showed there was an aneurysm at the ampullary region with a neck measuring 10 millimeters, communicating with the descending thoracic aorta. The aneurysmal sac had eroded the adjacent lung parenchyma, with hemorrhage noted in the surrounding lung tissue as well as thrombus inside the sac. So this is the CT scan. We showed this is the neck of the aneurysm. As you can see, some thrombus was sitting inside the whole aneurysmal sac, and the aneurysm was actually eroded into the lung parenchyma, which was the cause of the hemoptysis. And probably this was growing for some time, and it came into view only when the patient started having hemoptysis. This is the angiographic equivalent of the same shot which you are seeing here, showing depicting the aneurysm here. So aortic angiograms, we thought that we will take up the case for a device occlusion, because otherwise the gentleman would have to undergo an extensive thoracic surgery. Hence, we took after an informed consent, we took him to the cath lab, whereas aortic angiograms are obtained in 90-degree lateral and 30-degree RAO views, which showed an aneurysm at the region of the ductal ampulla, and there was no residual ductal flow. Now, these are the angiograms which were obtained. 90-degree lateral one, where you can see there's a nice round aneurysm, and this is the 30-degree RAO view showing the neck, delineating the neck further, and this was about 30-degree LAO view, which showed the neck to be in perfect position. Hence, we decided, that is myself and my colleague Debasree, we decided that we will go inside the aneurysm very, very slowly and carefully, because otherwise it has a chance that it might damage the surrounding structures and the patient might have torrential hemorrhage. The aneurysm was scaffolded with a 0.035-inch J-tip thermo wire, over which a 9-French ACE device occluder shield was ready loaded and parked just inside the neck of the aneurysm. And this is the angiograms which we take. So a 5-French multipurpose catheter actually helped us to accomplish this particular movement, and this is the J-tip thermo wire sitting inside the aneurysm, and which helped us to railroad the ACE device delivery system. So a 12mm ACE device from LifeTake was positioned and deployed across the neck of the aneurysm, and the post-procedure aortic angiogram showed the device occluding the neck of the aneurysm without any further contrast to pacification of the aneurysm. So this is the angiogram which we took very, very carefully after we had entered the aneurysm, and being extra careful that we do not damage any surrounding structures. You can actually see some feeding defects, which are the thrombus sitting inside. So there was some danger of the thrombus getting dislodged as well. Hence, we were extremely careful, and this was actually Debasree handling the catheter while I was injecting. Hence, this is my colleague Debasree, who has taken the device inside, and the LA disc has actually been deployed inside the aneurysm. As you can see, the LA disc is gradually deployed inside the aneurysm. It is taking its own position and it's being abutted against the wall, as the proximal wall. And after that, the RA disc is slowly getting released after the neck has been totally occluded by the part of the device. But after that, we had to be careful, and seemingly we have to make sure that we have not done any damage either to the surrounding structures or the distal thoracic aorta, where the remaining disc, that is the RA disc, will be butting against it. So still the device was held in position. So we have taken two outer lines, through which one of which the AZ device sheath was taken, and the other leg or the groin, we have taken a pictal catheter where we on angiogram we prove that there has been no obstruction anywhere on the distal thoracic aorta. And after that, they were to release the device gradually. As you can see, this is the release of the device. The device was released and stayed in position. There was no embolization, no other abnormalities. The patient's vitals were totally normal. There was no drop in blood pressure or anything. So this is the release of the device. So you can see it's released and it took its predestined shape. The neck of the aneurysm was snugly fitted by the intervening portion. That's the bridge of the device. And on angiogram as well, on an LEO view, we showed that there was no obstruction to the descending thoracic aorta. Vitals of the patient was completely normal and he tolerated the procedure very well. So the results: hemoptysis ceased dramatically after the procedure, and the hoarseness of voice gradually improved for the next 3 months as from the aneurysm over the laryngeal nerve was gradually relieved. Follow-up CT scan was done 3 months later, which showed that there was complete occlusion of the neck of the aneurysm with partial obliteration of the aneurysmal cavity. After 1 year, the voice recovered fully with no further hemoptysis. And this was the angiogram equivalent of the CT scan. And as you can see on the repeat CT scan, this aneurysm has totally solidified, and there was this disc, which is this aneurysm has totally solidified with the clot, and this is the descending thoracic aorta, which is there was no obstruction anywhere. Discussion: the hemoptysis after ductal ligation is rare and would generally point towards infective causes. In our case, the hemoptysis was due to the rupture of the aneurysm and erosion of the lung parenchyma by the large aneurysm arising from the ductal tissue in the ampule region. Pressure on the left lateral laryngeal nerve was causing hoarseness of voice. The pathogenesis of the aneurysm was difficult to envisage, but probably it originated from an outpouching of the ductal tissue from one of the suture sites. Surgical options were requiring extensive thoracotomy to be avoided in our case. And implications to clinical practice: continuous occlusion of ductal aneurysm is possible. It has a neck with enough available space to house the device. All possible causes of hemoptysis should be looked into in all presenting cases, including a CT angiogram, and the aneurysmal communications may be amenable to closure percutaneously. So Dr. Debasree has done quite a lot of research into this, and she came across quite a bit of a literature survey. So over to Dr. Debasree to carry out the discussion regarding the literature, what does it say, and what else can we do?
Yeah, thank you, Dr. Chattopadhyay. This was a seemingly easy solution to an unusual problem. I say unusual, even though this is not an unknown complication. So if we, when we looked back at the literature, we found that in 1961, in the journal Circulation, they had reported a case series wherein they reviewed 12 cases from John Hopkins Hospital's database. And in all 12 of them, there was formation of ductal aneurysm after ductal ligation. So they had hypothesized that this recanalization of ductal tissue is a forerunner for ductal aneurysm formation. All 12 cases in 1961 was tackled surgically. However, we are in 2020, and we try to find a percutaneous solution for many of our cardiovascular problems. So again, we have come across papers wherein people have demonstrated how percutaneously ductal pseudoaneurism has been tackled by several devices. And also it is known that pseudoaneurism or aneurysm can be tackled by endovascular stent graft. In our case, we were lucky to get away by putting a ASD device, and this gentleman's symptoms improved dramatically. I mean, within 3 days of putting in the device, his voice started to come back, and hemoptysis ceased the next day. So this was very gratifying to see how the patient improved dramatically. So over to Dr. Amitabha Chattopadhyay.
So this was indeed a very, very gratifying result, but he found that the results were very much evident. And after some time, after 1 year, the person was working for a firm and is completely healthy and has forgotten all his symptoms. So we like to share this particular case because as Dr. Debasree has done quite a bit of literature survey, the ascending and aortic aneurysms device closures are quite a bit more reported, whereas the descending thoracic aorta aneurysms are a little less in occurrence. And we have got a few reports, especially after PDA device closures. And in our case, we were not very much sure about the pathogenesis, but we thought that probably it was from some ductal tissue which entered into the aneurysm formation, thereby which may have occurred from the surgical sutures. That was our guess was. Anyways, the patient is quite well now, and thank you for this opportunity, enormous opportunity to show our case, which we had done in our hospital. Thank you very much.
Thank you. Thank you.